But as an oncology nurse, I think we need to start really focusing on some of the positive reasons why they need to stop in any prognosis that they have across the board. And I think that people respond to positive feedback better than the negative feedback. And that's why the benefits of smoking cessation for patients with cancer is so important to talk about. And again, that nurse might be the only cheerleader this person has to keep them motivated moving forward.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jamie Weimer, Oncology Clinical Specialist at ONS. And today we're talking with Maureen O'Brien, Clinical Nurse Specialist and Certified Tobacco Treatment Specialist at Memorial Sloan Kettering Cancer Center in New York, New York, about treating tobacco dependence in the cancer care setting. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Maureen.
Thank you for inviting me.
Before we get into the topic, we just introduced you as a certified tobacco treatment specialist. Can you explain a little bit more about what that role is and what are the requirements that you went through for certification?
So tobacco treatment specialists are professional clinicians who possess the skills, knowledge, and training to provide effective evidence-based interventions for tobacco dependence across a range of treatment intensities in a variety of contexts, treatment modalities with different types of populations. They're various professionals. We're very multidisciplinary. They work in various community settings, hospitals, health departments, medical and dental practices, social service agencies, telephone quit lines, alcohol drug dependence programs, behavioral settings. So you can imagine the settings are quite varied. You have to attend a council accredited training program. It's a 4-day program. You have to complete an application. We're in the process now of getting this certified. For right now, what you have to do is you have to attend this 4-day program. You have to pass their exam. You have to have 240 hours of competency-based practice post-training. And at that point, then you can sit for the national multiple choice test. Right now, you would get a certificate. We have a professional organization, and it's called ATUD, and that stands for Association for the Treatment of Tobacco Use and Dependence. And it's ATUD that is developing the certification. So the people who have done the certificate will then be transitioned into that certification. That is our goal, that we're having a national, international certification program.
Wonderful. Well, it sounds like a very thorough program and a necessary addition to our multidisciplinary approach of talking about tobacco dependence and how to help patients through that. So it's just great to learn more about that role. And hopefully a lot of our listeners either have one of this role or this position at their institution, or if not, then now they know it exists and maybe they can advocate for adding that to their team. So now on to our topic today. Let's start things off just talking in general about what are the most common forms of tobacco and how prevalent is the use of each?
Before I talk about the different forms of tobacco, I just want to make sure that people understand the difference between tobacco and nicotine. That is a real big concern when you speak to a lot of patients. So to start with, there's a very big difference between it. Tobacco is a beautiful plant, if you look it up. But what you must understand is that it is a poisonous plant. It's in the same category as poison ivy. Think about it. That's one of the reasons why healthcare professionals will always ask someone if they have a tobacco history, because we know that if you continue to ingest or inhale a poisonous substance, it will damage the body. When? Can't tell you that. How bad? Can't tell you that. But we do know that the more you smoke and the longer you smoke, the more the chances are developing these healthcare complications. Nicotine, though, is only one chemical in this product of many, but it's the only one that the person is addicted to. Nicotine doesn't necessarily cause any health concerns. And they realized that the FDA realized that if they took nicotine out of the tobacco, cleaned it up, and then put it into various other products, like the nicotine replacement therapies, they could give it to the person safely to help them quit smoking. People have this real crazy notion that it's the nicotine that they want to get rid of when they quit this addiction. But really what we want to do is get rid of the tobacco. So that being said, then I'm going to talk about then the various tobacco products that people use. I'll go in order the most prevalent to the least prevalent. So truthfully, right, the most prevalent are the cigarettes. Currently, 12.5% of the population nationally are smoking. It takes the average person 7 times of trying before they quit for good. Of that 12.5% that are smoking, 70% really, really want to quit. Again, it takes the average person 7 times of trying before they quit for good. If, let's say January 1st, everybody wants to quit on January 1st. Of that 70% who really want to quit, 40% will make a quit attempt on January 1st. If they do not use nicotine replacement therapy and or counseling to go along with it, by the end of the year, less than 5% will be successful. So if you think about it then, cold turkey has a success rate that's less than 5%. And that's basically not what we want to do. We want to offer people better success. We know that if you use, let's say, the nicotine replacement therapies, you can double or triple your success rate. So that's something, especially when we think about oncology patients, that becomes really important. We want to make sure that we're offering them treatment options that gives them the best chance possible. The other thing you need to understand about cigarettes is that the pH balance is more acidic. It's like 5.5. And as a result, it gets absorbed deep into the lungs. Because of that, it only takes 7 to 10 seconds for the nicotine to rush from the lungs, the heart, the brain in 7 to 10 seconds. So the faster a drug reaches the brain, the more addictive it is. That's one of the reasons why this addiction is so intense. 1, the nicotine rushes to the brain very, very quickly. 2, it's probably one of the only addictions out there that allows people to function appropriately in society, which then is so much more reinforcing. So people have a real difficult time with quitting this. If you ask the patient, they'll tell you that it helps them and helps manage. Well, yes. I mean, if people are using it to help manage their stress and they get results in 10 seconds, why wouldn't you want that? I don't have a drug on the market that can work that fast. So that's something that we really need to think about. That's really hard for the oncology patient in terms of getting off of the cigarettes. The second biggest product then is the electronic devices, the electronic nicotine delivery systems. With that product, I'm including the Juul. A lot of times people will say, well, I have a product and it doesn't have nicotine in it. I'm using the electronic cigarette and it says no nicotine. I'm telling you for a fact that if they continuously use it on a regular basis, regardless of what the product says, remember that this is a product that's developed by the tobacco company, so they basically can come up with their own definitions of what the content of nicotine is. So if this person is using it on a regular basis, I'm telling you for a fact that it has nicotine in it. So that's something that we need to consider. It is the biggest product, the most widely used product among the adolescent population right now. And that is a big concern for us. We have about 1 million smokers who have switched from traditional cigarettes over to electronic cigarettes. And it really becomes a topic of controversy for a lot of healthcare providers. We have some people who truly believe that nobody should be using electronic cigarettes. Where on the other side, we're looking at harm reduction, where we do have some smokers who have very extensive smoking histories. And I'm talking about like 30, 40, 50, 60. I have worked with people who smoke 70 cigarettes, and I have worked with people who smoke 80 cigarettes a day. That's 4 packs a day. And so those people have had somewhat success in reducing their smoking by using the electronic cigarettes simply because they're not ready to give up the act of smoking. But again, it's a very touchy topic. It's very controversial. So it's something that we have to look at in terms of, is it really something that we want to use moving forward? That's going to be a hot topic for a long time. The next biggest product that is out there then is the cigar. We're talking about the traditional cigars, cigarillos, the little cigarettes. When you think about that celebratory cigar, it's usually that traditional Cuban cigar. 1 cigar is equivalent to 15 cigarettes. That person who is using that celebratory cigar is basically getting the ashes from 15 cigarettes. The pH balance of a cigar is different than the pH balance of a cigarette. The pH balance of the cigar is alkaline. It's like 8.5. And as a result, it gets absorbed deep in the esophagus and the mouth area. It makes sense now, right? People who smoke cigars have a higher rate of esophageal and head and neck cancers. What's interesting about this, and this is what people need to understand, is that when you're working with cigar smokers, the first thing they'll say to you is that it's not dangerous because I don't inhale it. Well, people who smoke cigarettes will inhale the chemicals into the lungs because they know how to really manipulate their smoking. People who are not regular cigarette smokers, their absorption, because of the pH balance, again, is more in the esophagus and head and neck. So that is something that a lot of people don't realize, that yes, you may not be absorbing it into your lungs, but you certainly are getting the tobacco absorbed in other areas of your body. And that's where the problem then occurs. And then we have our pipe smokers. And then we have the smokeless tobacco and snus. Then we have the hookahs and the critiques and beaties. Critiques are cigarettes that are rolled with cloves, and the beaties are cigarettes that are rolled in flavored papers. And that's basically the types of various products that are people using on a regular basis.
That's very interesting. And thank you for that summary of all of those different products. I certainly think, I'll speak on my own behalf. I always assume and just kind of jump right to the cigarettes and tobacco, although more so now with, the electronic delivery devices, as you mentioned. But as you mentioned, it's important to keep consideration of all of those different types of products. And certainly that might vary across the country of where your patients live and what is kind of endemic in their culture or in their environment. And so it's always important to, when you ask a patient, do they smoke? Well, maybe they'll say no, but you need to clarify like any of these products, not just cigarettes. So important to keep all of those different various types in mind. So now let's talk about just in general, what are the health risks? Of course, as nurses, we inherently know that there's risks and could probably name a few off the top of our head, but it's always good to review. So what are the health risks that are typically associated with tobacco use?
For every person who dies from smoking, at least 30 people will live with a serious smoking-related illness. So smoking causes cancer, heart disease, strokes, your lung diseases, including your COPD, which include emphysema and chronic bronchitis, and diabetes. 87% of all our lung cancers are directly linked to smoking. 32% of all our coronary artery disease deaths are directly linked to smoking. 79% of all our COPD cases are directly linked to smoking. 1 out of every 3 cancer deaths are directly linked to smoking. So an example of that is that I was working with someone who had testicular cancer, newly diagnosed. He was getting bleomycin. He was a young man too. Of course, if you know anything about bleomycin, it can cause a lot of damage to the lungs. And so he smoked about a pack a day, and he had gotten down to 2 cigarettes a day, but his pulmonary function tests kept getting worse and worse. And the doctors were begging him to quit. So he had come in one particular day and he had been down to 1 cigarette, but he had his treatment. He wound up having respiratory problems, and it wound up that he wound up passing. And he didn't die from the cancer itself. He died from the association between the bleomycin and the continued smoking. So 1 out of every 3 cancer deaths is directly linked to smoking. In 2014, the general surgeon put on the list that colorectal and liver cancers were directly linked to smoking. And of course, there's a very strong association between type 2 diabetes and continued smoking. And then you have your other problems. You have age-related macular degeneration. You have basically a diminished overall health status. It impairs the immune function and it reduces basically the quality of life. So there are a lot of health risks that are associated with continued tobacco use.
Absolutely. And I think a lot of patients might say that even though maybe it's not the most prevalent, as you've mentioned with your statistics, but once a patient reaches our doors and they have a cancer diagnosis, then that can sometimes feel like the most serious, threatening diagnosis that can be related to their smoking. And so I think a lot of patients, when they enter into their cancer diagnostic journey to figure out kind of what comes next, certainly the recommendation to stop smoking comes often early, but it's not that simple. Even if a patient recognizes that their smoking history or their tobacco use history has maybe brought them to where they are today with their cancer diagnosis, or certainly contributed to it, it's not always that easy for them to quit even in that. There are barriers that exist even once a patient has developed cancer. Can you expand a little bit more on all of the barriers that a patient might face when they're still using tobacco in the midst of their cancer care?
So I'm really going to specify it related to the cancer patient, because in general, there's so much stigma associated with continued smoking, but especially with the cancer patient. We know through research that cancer patients exhibit feelings of guilt, shame, blame, and regret that they even started smoking. So think about this. When someone gets diagnosed with a cancer and they're not a smoker, the support and the love that they get from family members sounds something like this. Oh my God, how can I help you? I feel so bad for you. What can we do? There's just so much concern and love. But when someone gets diagnosed with cancer and they smoke, they get a little bit of that support and love, right? But then they get comments like, well, you are going to quit, aren't you? You're not going to continue smoking. You'd be an idiot if you smoked. You got to be crazy. This is crazy. How could you continue smoking? Maybe if you quit smoking 5 years ago, this wouldn't have happened. And if you noticed, that's not very supportive and kind, is it? And smokers get that all the time. And I know that because when I speak to smokers, some of the first things they say to me are, you must think I'm such an idiot for still smoking with cancer. I've got to be crazy. I'm crazy in my head. Something's wrong with me. Those are all negative connotations that this person states. So one of the things that we know is that when and if a patient continues to smoke with a cancer diagnosis, it's because there's a high nicotine dependence. They're smoking to manage their withdrawal symptoms. The biggest withdrawal is anxiety and depression. And one might say just being diagnosed with a cancer diagnosis is very anxiety provoking. So what the person who doesn't smoke doesn't understand is that when the cancer patient gets diagnosed with cancer, they get very, very anxious. And the brain, the nicotine receptors in the brain will actually tell them to have a cigarette, where a non-smoker would never have that reaction. So there's high psychological distress. This patient knows that they should not be smoking. They understand that in their heart. It's just that their brain is telling them something different. They have not developed alternative coping strategies to manage their stress. So when they get stressed, the first thing they think about is having a cigarette. And if the cigarette manages their stress in 7 to 10 seconds, like I said earlier, then why would you want to go through any of the other strategies when something works in 10 seconds? So there's low quitting self-efficacy, confidence. If you've tried 7 to 10 times and you haven't been successful, then after a while you start to lose a little confidence. And so we need to then build up on that confidence. There's knowledge deficit. So if this information that I'm giving you today is new to you as a healthcare provider, then what do you think your patients know or their family members know? There's a lot of misnomers out there, a lot of myths that are associated with continued smoking. And we need to make sure that people have the facts in order to move forward in the correct way. And whether this person wants to quit or not, there's abrupt cessation versus commitment to abstinence. So you have a lot of cancer patients who will say to you, I'm not ready to quit. Totally understandable. That's one of the reasons why our program is called Tobacco Treatment Program, not a smoking cessation program. Smoking cessation means that someone needs to quit smoking. We are tobacco treatment. We will work with a patient in any stage of change they're in. So if a patient is not ready to quit, that is fine. But there's a lot of studies that show that even cutting back in half can be very health benefits to the patient. And so that's one of the reasons why we do that. So if someone doesn't want to quit smoking, when they come into a hospital setting, you're basically putting them into a state of withdrawal, whether they like it or not, because they cannot smoke. When they go to a doctor's office or they go for chemotherapy and what they thought was going to be a few hours turns into like 7 or 8 hours, you're putting them into a withdrawal. Again, anxiety, depression, irritability, restlessness, difficulty concentrating, and those withdrawal symptoms can be very, very uncomfortable and intense. So those are some of the barriers that we need to think about and we need to work with. Perhaps maybe that person coming in for chemo who does not want to quit, maybe needs to be offered a nicotine patch during the treatment process. In a hospital setting, we'll often offer people nicotine replacement therapy, even though they don't want to quit, just to simply manage the withdrawal while they're in the hospital setting.
I think how you've just described the importance of what we say, the words that we use, how those certain words can have connotations or bring other emotions in. It's just so important. You used, like treatment versus cessation. I mean, as you said, that means something different. It makes me think of naming things as cancer prevention activities. We really need to move towards cancer risk reduction. That implies that if you follow it, then you'll prevent cancer versus we know that it's never one single thing that creates that cancer diagnosis. And so changing that terminology to really reflect what is true then also impacts the patient and how they feel about themselves and how they, perceive their ability to do something different. So thank you for bringing that up. I think that's really important.
Instead of referring to them as a smoker, we should be referring to them as a person who smokes.
Absolutely.
It's a little different.
I think that's perfect and exactly the same idea. Even though sometimes when we're talking kind of amongst nurses, we'll say, oh, well, my cancer patient, it's a patient with cancer. We know that that's the right way to say it because this is a person first that happens to have a diagnosis or has an addiction. Changing that terminology and trying to catch ourselves, correct ourselves, even when we misspeak unintentionally, the words matter and how we speak about those things make a difference. So let's move on into how smoking can affect the actual cancer treatment itself and the side effects that patients experience. You gave a great example with the bleomycin. Do you have any other comments or examples to give on how smoking or tobacco use can affect cancer treatments?
So what I told you earlier, right, was that tobacco is considered a poisonous plant. And if you continue to ingest or inhale, it's going to damage the body in some way. So we know for a fact that if a person continues to smoke, there's a failure rate of all treatments across the board. So we're looking at surgery, radiation, chemotherapy, and palliative care. There's a lot of times someone might say to you, well, my cancer is not related to my smoking at all. Right. But we're going to be giving you chemotherapy or radiation that affects the heart or the lungs. And continued smoking is going to have effects on that. So in terms of surgery, the person doesn't heal as well. There's pulmonary effects. Many times the person who's going for surgery needs more anesthesia than the person who does not smoke. So that adds to the complications of pooling of secretions. Their circulation is not as good. So there is an increased risk of a heart attack for the person who's going for surgery. Radiation and chemotherapy have a lot of side effects that are related to the treatment. And if you continue to smoke, we can make those side effects occur maybe sooner or more intense than the person who doesn't smoke. And the last one I want to talk about is the palliative care. A lot of people will say, let them be. They're stage 4. What is it going to matter at this point? Well, one, you have to think about, why are they coming to your center? Why are you treating them? You're treating them because they want to perhaps maybe try this treatment and they realize that it's not going to save their life, but it could give them a few months. So again, we want to make sure that the treatment can work as effectively as possible. We want that person to at least refrain from smoking. If the word quitting is too intense, then don't use the word quit. Use refrain. They'll stop smoking. They refrain from smoking during the treatment process. Palliative care, there's still health benefits. The health benefits, one of the biggest one is being able to breathe better. Even at the end of life, don't you want this person to be a little bit more comfortable in terms of their breathing? A lot of people have this thought that smoking helps with the pain, but the truth really is that it doesn't. People who stop smoking actually have better relief of their pain. So it's better pain control. When someone's going through withdrawal, the anxiety, the restlessness, and difficulty concentrating, sometimes pain medication doesn't work as well. The truth is, in the palliative care, we can make them more comfortable, breathing-wise and pain-wise. And then remember that this person has been trying to quit forever. And perhaps maybe they want to end their life knowing that they finally accomplished something they have been trying for many, many years. So we need to think about that. Also in palliative care, you need to think of safety. I get it. Not everybody can quit smoking, and we're not going to get everybody to quit smoking. They're going to continue to smoke. But if that's going to be the case, then they need to make sure that they're safe. So how many times have we discharged patients home with oxygen and they continue to smoke? Do they understand that they shouldn't be smoking around the oxygen? Do they really understand? At some point in the disease process, the dexterity of their hands start to go. Are they able to light the cigarette on their own? Are they able to hold the cigarette? Because I can tell you for a fact that I have worked with many a patient whose family member has lit and started the cigarette for them. And I don't think that that's very safe. And so the last thing is that when somebody refrains from smoking for a period of time, and you ask any smoker, they'll experience this, and they finally have that cigarette, they get a bit of a head rush and they get palpitations, they get a little sweaty, a little dizzy. Well, you think about the treatment that we're giving, and then we're having this person who smokes an occasional cigarette, who's now getting dizzy, a little head rush. And so one of the things we need to understand from a safety perspective is that if you're going to discharge a patient from the hospital, right, and they haven't been smoking for 5 days, they're going to get that reaction anyway. One, they need to make sure that they tell somebody they're having a cigarette. And two, they have to be in a sitting position. because of the treatments that we're giving them. We don't want to increase their chances of falls. And I don't think that people ever think about those things, but it's really important to do this.
I think those are really great comments on just thinking about what happens when they stop, but also what happens when they restart again. If they do, if they do refrain, as you mentioned, again, that change in terminology and how important that can be for patients, just for them to reframe it in their minds. But then also considering, as you mentioned, like if they do resume it at some point, just being mindful of keeping them safe and making sure they have the information and the knowledge so that if they're going to continue to smoke in the context of cancer treatment, palliative care, any of those things, it's just a different landscape than what they're familiar with from before. So there's still a nursing role in that setting, of course.
Yes, actually, I just want to add one other thing that's associated then going back to the barriers. So this person is going through treatment. The family is thrilled that they stopped. And then the person relapses and they're smoking the occasional cigarette. In all fairness, do you really think that that person is smoking around their loved ones, or are they hiding the cigarette? Most of the times they're hiding, and they'll tell me things like they don't smoke until their family members are gone. They get in their car and they drive someplace else. They go in the backyard so nobody can see them smoke. And again, the hiding is what's really bad, because that person is by themselves. They need to make sure that, again, they're in a sitting position. It's just so embarrassing for that particular person when they're caught having that occasional cigarette. So it's something that we really want to think about.
And it goes back to your original comments about just the shame and just the whole psychological piece of that, in that, again, that patient should not feel judged, should still be supported. It's complex. It's very complex.
Yes. And we're not very nice to our smokers, are we?
Right. Even loved ones, even family members, you want the best for them. You have good intentions, but that's not coming through in that message, right? It's adding more stress and more psychological distress for that patient. Well, you've talked a little bit about the benefits of smoking, but I think I would say most nurses can say they've gotten the reply like, well, why should I quit now? I already have cancer. So can you talk a little bit about what those benefits, even the very extreme short-term benefits are of quitting smoking or refraining from smoking for a period of time? What benefit can that bring to the patient?
It improves the prognosis overall. The benefits occur within the first 20 minutes of not smoking. Your heart rate and blood pressure. If you look up in the literature, it says it decreases, but I say it normalizes. We have a normal range for our blood pressure. And when you stop smoking, after about 20 minutes, your blood pressure starts to normalize. Of course, you always have that person, that little old lady who's smoking 2 packs a day and drinks the 3 pots of coffee a day, who will always tell you that their blood pressure is very, very low, which we don't want either. We have a range. And so when they stop smoking, we can probably get them into a normalized range of their blood pressure. It only takes 8 hours for the oxygen levels in the body to start to increase. When you continuously smoke, there's always some damage to the lungs. And as a result, one of the byproducts of the tobacco is carbon monoxide, and that is retained in the lungs. Carbon monoxide directly competes with oxygen. And in 8 hours, we can start to reverse that. And we want that because in 24 hours, the risk of a heart attack decreases if you stop smoking. In about 2 weeks to 3 months after stopping smoking, your circulation starts to improve and your lung function increases. Why? Because the cilia in your lungs are starting to regrow. And it's the cilia that really helps bring up the secretions that the person needs to get out. In 1 to 12 months after quitting, the coughing and shortness of breath start to decrease. Again, the cilia starts to grow back and move the mucus out of the lungs to regain a normal function. It increases their ability to handle it and clean out that lungs. And I'm talking about the smoker's cough. In about a few months, that smoker's cough, they'll be able to start bringing up those secretions. In 1 to 2 years after quitting, the risk of a heart attack drops dramatically. 5 to 10 years, your risk of cancer start to go down. And 10 years after, your risk of lung cancer is about half of that of a person who is still smoking. At 15 years of quitting smoking, your coronary artery disease is close to that of a non-smoker. And so if you can get that person, let's say, who's age 40 to quit smoking, and they do not go back, the chances of them dying from any type of a smoking related illness is quite reduced. So we always want to talk about the benefits instead of the complications associated with continued smoking. We learn that when we talk about the positives as opposed to the negatives, right? And so that's one of the things that perhaps as healthcare providers, the doctor's coming in and telling them they have to quit because it's dangerous, whatever. But as an oncology nurse, I think we need to start really focusing on some of the positive reasons why they need to stop in any prognosis that they have across the board. And I think that people respond to positive feedback better than the negative feedback. And that's why the barriers, that's why the benefits of smoking cessation for patients with cancer is so important to talk about.
I couldn't agree more. And I think, as you said, this is where oncology nurses can shine. All of our healthcare providers, part of the multidisciplinary team, need to continue to reinforce the message of you should cut back on your tobacco use. You should try to eliminate tobacco. But nurses, I think, are the ones that see that patient most often, as we know, especially if they're in recurring outpatient treatments where we'll see them. If we know that they're a smoker, we can always ask, hey, how are you doing with that? How's it going? What are you struggling with? Remember, it can help if you can just stop for, a few hours or a few weeks, just encourage them along the way versus the physician coming in and kind of being the heavy and just saying, you got to quit. It's killing you. There's ways that we can continue that message in that more empathetic and supportive way. And so I think that's for oncology nurses to remember is that they have a lot of roles. We know that we're doing a lot of things, but we should never forget that sometimes hearing it from your nurse might mean something different.
I think the oncology nurse needs to understand that they might be the only cheerleader that patient has. And you know that because you listen to what the family says to them. The family wants them to stop smoking, and I get that. But sometimes the patient is struggling, and going from 20 cigarettes down to 2 is not so bad. With time, it took them years to learn how to smoke 20 cigarettes. It's not going to take 3 days for them to stop. And I think that that's what people need to understand. This is a process. Just like losing weight is a process. You cannot lose 100 pounds in 3 days. That person needs to be supported through this. And so when someone comes in, let's say with chemotherapy and they're continuing to smoke, the family member can be very upset with them because they have to quit smoking. But it's the nurse that might be able to say, well, you've gone from 20 to 2 cigarettes in a short period of time. That's really quite beneficial for your body. You've stopped smoking in the home. You've stopped smoking in the cars. These are all positives that you need to look at. And again, that nurse might be the only cheerleader this person has to keep them motivated moving forward. And that's what we need to do. We need to make sure that our patients' motivation and confidence stay high so they can continue on this journey of quitting.
Absolutely. Yeah, that empathetic delivery of communication of just not only pressing them to try harder or do better or understand how their tobacco use can influence their treatment or their side effects. All of those things, nurses can deliver that message in a way that sometimes other providers can't. And I think they'll hear that message in a different way. Sometimes it's not what you say, but kind of how you say it and who is saying it. So again, just for nurses to keep in mind of just the importance of their voice and how reinforcing that message with their patients, because they have a special and a different relationship with those patients, it can be meaningful. So just always keep that in mind. All right, so let's move on from talking about sort of the benefits of quitting and the risks that we know are inherent with tobacco use. Let's talk about the treatment phase. So as clinicians, when we see these patients, they come into our care and we know that they are continuing to use tobacco. Can you discuss in more detail, what are those best practices for treating a tobacco dependence? And are there any guidelines or programs available for healthcare professionals in the cancer care setting?
Oh, there certainly are. Let me just step back a second, though, and just let you know that I've never been in a job such as this one, where patients tell me in so many words that I don't know what I'm talking about. And what I mean by that is that I might suggest nicotine replacement therapy, and a patient will go, oh, no, nicotine replacement therapy doesn't work at all. I heard it's really bad for your body. I mean, it's interesting that sometimes people will go to Google or they'll go to products from the tobacco company before they go to a healthcare provider. And what people need to understand is that there are clinical practice guidelines for treating tobacco use dependence that guide our practice. These guidelines provide recommendations for clinical interventions and system changes to promote the treatment of tobacco dependence. The recommendation is to use evidence-based treatment, which include both behavioral therapies and FDA-approved medications. And the FDA-approved pharmacotherapies I'm talking about are the 5 various forms of nicotine replacement therapy: the nicotine patch, the nicotine gum, the nicotine lozenges, the nicotine spray, and the nicotine inhaler, as well as the 2 medications that we have that help people quit smoking, which would be bupropion, or what we refer to, brand name is Wellbutrin or Zyban, or varenicline, and the brand name is Chantix. And those are the medications across the board that we all suggest and use. So if you spoke to someone in New York, we're going to talk about this. And if you spoke to somebody in Florida, Alaska, Hawaii, we're going to talk about the same thing. So we're all on the same page because we all use the clinical practice guidelines.
Are there any specific training programs that follow these guidelines that you are familiar with that you'd like to mention?
So keep in mind, I think I said earlier that Memorial Sloan Kettering has a training program for the assessment and treatment of tobacco dependence in the cancer care training. This training will prepare learners to provide safe and effective evidence-based treatments for tobacco dependence for the cancer patients, survivors, and their family members. Many institutions offer training programs in the country, and these accredited training programs are, as I said earlier, a 4-day program. But we also at Memorial have a program specifically for the oncology provider. We have a 2-day program, didactic program, where we really talk about the strategies of helping the healthcare provider work with patients who have cancer who continue to smoke. And it's really having this empathic communication involved in it and really understanding the challenges for a cancer patient to quit smoking are a little bit different than the regular population. So we need to be a little bit more sensitive regarding that. And it's an excellent program. We just completed last week our 16th program that we've done. Every program, we seem to be getting more and more people. And I think from an oncology perspective, this is a wonderful, wonderful program for our oncology nurses to consider attending.
That certainly is a great opportunity. And we'll be sure to include links to that information so that our listeners can explore that if that's something that they want to maybe dive a little deeper into. But even if they don't, we've talked a little bit about the importance of the nursing role in coaching patients through this part of their care. Can you talk a little bit more about the steps that nurses can take to help provide the education and the assistance that patients need to promote and support them through successful smoking cessation?
So the healthcare providers can help patients quit by, of course, using the 5 A's, but I like to use the newer version of ask, advise, and refer. It's simpler. And you need to understand it only takes 3 minutes to do this. So a lot of times I might have a healthcare provider saying, I don't have the time. Yeah, it's 3 minutes. That's it. You want to offer brief counseling, advise them to quit or cut back. Consider some type of a cessation medication, making sure that they really understand it, prescribing it, getting the physician to prescribe it, connecting them with additional resources. And if need be, maybe their health department in their neighborhood, even the quit line, the national quit line. And then the importance would be follow up for their next appointment with documentation in the chart. So it doesn't really take that much. But again, what that would do for the patient is to really see that this healthcare provider is really dedicated to assisting them with quitting smoking.
That's a great and a simple message of just, it's not a labor intensive process or a huge ask, especially when you think of nurses and how busy they are. It can feel daunting just for one more thing they have to do, but it can be just as simple as that. And doing it repeatedly, every time they come, ask them how they're doing, ask if they're ready now. Maybe they weren't ready before. It's not a one and done kind of conversation. So thanks for providing that quick and simple approach to how nurses can still have that impact on a patient. Well, Maureen, thank you so much. You've provided lots of great information. I think a great overview and a good foundation for nurses that I think, again, we all inherently know tobacco use and smoking is bad, but if you asked me to get into the details, maybe I couldn't have provided those. So thank you for all the great information you've provided today. As we wrap up our episode, we always like to ask a few summary questions that help just reinforce some great points that we've discussed. So to start things off, what are some common misconceptions about smoking cessation for patients with cancer?
Oh, there's just so many. Nicotine, patients really truly think it's the nicotine that's the major culprit in the cigarettes that's causing all the problems, when in fact it's not the nicotine, it's the tobacco, which is something that's really important to understand, because a lot of times patients will say things like, well, I don't really inhale, or I'm just having one. It's not so bad. It is the tobacco we don't want. Nicotine is what they're addicted to. That's one of the reasons why we always want to consider giving them nicotine in a different form with a different absorption, hence the nicotine replacement therapies. A lot of times the myth is that nicotine replacement therapy is as harmful as smoking. Patients will say things to you like, Why do I want to put nicotine in my body if that's exactly what I'm trying to get rid of? I heard that if you smoke with a patch, it could kill you. It's dangerous. I don't want the nicotine replacement therapy. Well, that's the other one. Smoking while using nicotine replacement therapy is dangerous. I don't want to put anything bad in my body. I heard that you can get a heart attack. I don't think that they're safe. One, the doctors would never recommend you to use the nicotine replacement therapy if they didn't think it was safe for your body. Nicotine replacement therapy does not interfere with any treatments. So that's the other thing that we need to understand. Nicotine replacement therapy is not going to make them quit smoking. It's simply going to make them feel better so that they can work on behavior change that's needed to quit smoking. Sometimes people will say to me, using one or more nicotine replacement therapies is dangerous. Well, our standard is combination therapy, the nicotine patch with the nicotine gum, Chantix with the patch, and let's say the nicotine gum. Studies have found that the use in combination is much better than monotherapy, and yet people are not aware of that. People say, especially in cancer, that their smoking helps relieve their stress, where studies have actually found that stress decreases when someone quits smoking. Because if you think about it, someone smoking a pack a day, they have cancer. Their family and friends don't want them to smoke. So 20 times a day, they're running around trying to figure out when they're going to get their next hit because they don't want to do it around family members. And they realize it's very complicated. You wake up in the morning and you have to think about where you're going to smoke. Can't smoke in the home, can't smoke in your car, can't smoke at the doctor's office, can't smoke at work. When are they going to get their next fix and smoke when people don't see them? So when you take that away, the stress actually decreases. Sometimes people think that the mild cigarettes reduce the harm from smoking. They switch cigarettes. And so mild cigarettes are so much better. Well, in essence, that's not true either, because one of the things that they found when they went to light cigarettes is that they didn't decrease in their cancer risks. What they did was they changed the type of cancer. So people who smoke regular cigarettes have a higher rate of squamous cell carcinomas, where people who smoke light cigarettes have a higher rate of adenocarcinoma. That's one of the reasons why the words light was taken away. And the tobacco companies have now used more of a color coding to signify different types of cigarettes. Another myth is smoking just a few cigarettes daily is harmless. It's not really considered smoking. I don't really inhale. I had a patient who was in her 80s who smoked about 30 cigarettes a day, and she insisted for 30 years. She never once inhaled. And I'm telling you, if you continue to smoke, you're getting the effects of the nicotine. So that is not true. People want to use hypnosis, laser, acupuncture. That's usually the first things out of their mouth, electronic cigarettes, without thinking about the stuff that we know work, the evidence-based treatments. We do not have a lot of evidence that proves hypnosis, laser, acupuncture works at the end of the year. So why are you suggesting a method of quitting when the effectiveness success rate is so much lower than a product that we know can double or triple your success rate? Another myth is that it's too late. The damage is done. Well, when I talked about the health benefits, even at end stage, I think as a healthcare provider, it's our duty to suggest ways in which we're going to increase comfort for this person. Suggest that person, even at the end stage of not smoking, we can improve their breathing a little bit. We can improve their pain a little bit. We can improve their stress a little bit. And I think that those are something that are worth talking about. And then the other one, oh dear Lord. So the best drug we have out there that helps people quit smoking is Chantix. And yet that is the one drug that people always say, oh my God, I don't want to take Chantix. I heard that people are killing themselves, jumping out of buildings, committing suicide on that particular drug. Well, that black box warning, especially for the mood, was taken away. And that is not true. It's one of the reasons why people who use Chantix have the highest rate of success with quitting. Those are the top myths that I can think of.
Well, clearly lots of myths to help, nurses can help resolve. Like this is where nurses can know the right answer, know the truth, and help to dispel those myths if that's what they hear their patients talking about. So thank you for sharing that. What's something about this topic that's not often discussed, but you wish people knew more about?
The biggest one I want people to get from this is that tobacco is a poisonous plant. If I told you that the red dye in Gatorade was poisonous, oh my God, there would be campaigns to get the red Gatorade off the market in a minute. And yet people continue to purchase this drug on a daily basis. It's just mind-boggling to me. Here you are trying to fight this cancer, and yet you continue to use something that we know is detrimental to the body. And that's where the addiction piece comes from. That's why this person needs help in quitting. That's the other thing I want people to understand is that one, you can't quit in a day. You can't quit in 3 days. It took you a while to start to smoke, and it's going to take a while to stop smoking. It's a process. So that's one thing. People will say, oh, it's all in my head. You have to want to. You have to be willing. It's not about willpower. Again, this is an addiction that people need help with.
That's always a great reminder of just keeping that perspective that it's not just a choice. It's an addiction. It's a psychological, physiological addiction. So certainly worth remembering. We touched about this a little bit. Are there any additional training or education opportunities or programs that oncology nurses should consider if they want to understand or approach their smoking cessation discussions with their patients differently?
Yes, like I said, that Memorial Sloan Kettering has a 4-day training program to help healthcare professionals in the delivery of tobacco treatment. We also have the 2-day training didactic program that will specifically help people in the cancer setting. Actually, I should say healthcare providers providing help for cancer patients who continue to smoke. But on the other side of things, though, we do have other resources such as quitassist.com. We have the CDC. We have the American Cancer Society, American Lung Association. You simply have to Google those. They have materials, excellent materials are always updated on a regular basis. You have your programs through your local health departments that people can reach out to. So there are a lot of resources, and many of these resources, including the Quit Line, also have options for language, various languages they can use. And we have a lot of these materials that are developed that really cater to, let's say, we have education materials in Spanish, Russian, Arabic is a big one, Chinese, that's a very big one. So you can go on these sites and get education materials in various languages too. That's the other plus side of things. We're really trying to think in terms of diversity and really trying to reach a lot of people.
Well, thank you so much for providing those examples. I think what I've learned, especially from our conversation, is that it's, nurses kind of know, smoking's bad, tobacco is bad, but we've talked about how there's a nuance to delivering that message and communicating and connecting with your patient to support them through what we know can be a long journey to ultimately quitting if that's where patients end up. And so I think it would be great for every nurse to kind of re-educate themselves on, I know it's bad, but what else can I do? What is my role in this discussion with patients, and how can I be supportive as they go through not only their cancer treatment, but their journey to smoking cessation? So thank you for providing that information. Do you have any final comments to share with us today, Maureen?
Yeah, one, thank you for inviting me. And I think it's simply because I'm so excited to be able to provide this information to the Oncology Nursing Society group. They are instrumental in helping get people quit smoking. I think our ONS nurses know how to really work with patients who have cancer and really understand the struggles and the challenges our patients have. And I think that they could be just such an inspiration for patients by the way in which they communicate the need to stop smoking. And that's why I think it's so important as we move forward for ONS to really include more programs on how to help people quit smoking, more lectures, let's say at the conferences on this topic. It needs to be something that's in the forefront. We need to get our cancer patients to refrain from smoking. And I think that the ONS group can be so powerful in this process. And I want to thank you then for inviting me, because I think that this is the start of this.
Absolutely. Well, it's been wonderful to have you on our podcast today, and I've enjoyed your enthusiasm and your expertise. And I know all of our listeners will learn a lot from this episode. So thank you so much.
You're welcome. Thank you for inviting me.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.